So a couple of things we're going to get into when we get into Therex here is we're going to start talking about soft tissue injuries, how they get injured, what type of injuries we look at, and then kind of the repair and the management of those. So when we talk soft tissue injuries, what does soft tissue injury mean? What is encompassed in soft tissue injury? What do you think? How about tendons? Would they be included? Is that going to be soft tissue? Is anyone awake? Bueller? Okay, there we go. Thank you, Renee. Just checking. Yeah, so when you hear soft tissue injury is anything other than bone. Bone would be a hard tissue injury. So soft tissue injuries can even encompass nerve damage, which we're going to talk about a little bit later. We're going to specifically talk about nerves. And then one of the labs we're going to do on Thursday is we're actually going to work through doing some manual nerve glides and see if we can make people's hands and arms numb, because that sounds like fun. So soft tissue injury, right? These are kind of examples of injuries and lesions that can occur when we're dealing with those soft tissues, right? A sprain and a strain. You hear these terms quite frequently, right? A strain is what you do to a muscle. A sprain is what you do to a ligament. And I put an asterisk there because some doctors use them interchangeably. Some doctors will say that they've got a sprain of their quadriceps. And it's not good to look at a doc and go, don't you mean a strain of their quadriceps, doctor? No, don't do that. Just go, okay. And just understand that in our terms in physical therapy, that's a strain, right? Because you're actually physically straining the muscle to do stuff, whereas you're spraining or stretching the ligaments when they're injured. Subluxation and dislocation. A lot of time these terms get tossed around almost synonymously, but they're not, right? Dislocation is where, like if I'm talking of a dislocation of the shoulder, the actual humeral head is completely and utterly out of the joint, out of the glenoid fossa, right? That's when we're talking about a full dislocation. It can dislocate it superiorly, inferiorly, anteriorly, posteriorly. Doesn't matter which way it dislocates, it's completely out of socket. Subluxation is a partial dislocation. What that means is, if I'm talking about that humeral head again, it's still touching part of that glenoid fossa, but it's just not where it should be. A lot of times with subluxations, you'll see them sublux inferiorly because the superior muscles aren't strong enough to hold that in place anymore. That happens a lot with strokes. Muscle tendon ruptures or tears, these are the ones we don't want. The patients don't like a lot, right? And there are a couple of different types you can get. You can get a complete, a partial, you can get an avulsion tear. Does anyone know what the difference between a tear and an avulsion tear is? What happens with an avulsion? So if you had like an Achilles avulsion tear, you're actually going to pull part of the calcaneus with the muscle tear. So you're going to yank off part of the bone. Oof is right. Well, so that typically most people, when they talk about popping their joint out of socket and coming back in, most of the time they're doing subluxations. Most of the times. If you can do a full dislocation and pop it back in, you've destroyed a lot of tissue, right? Because when you're dislocated, you got to think about it. That labrum and all that stuff is getting chewed to heck. I think of a lot like the first Lethal Weapon movie, right? Where they showed Martin Riggs is able to dislocate his shoulder and get out of a straitjacket. I'm pretty sure it was more of a subluxation than it was dislocation. Yeah, when it rolls out, that's more of a sublux. Because you can even sublux anteriorly, superiorly, inferiorly, posteriorly as well. It just tends to sublux inferiorly most of the time. Tendinopathy and tendinous lesions are when we have a problem with the actual muscle tendon, but the muscle itself may be fully healthy. Synovitis, inflammation of that synovial joint and synovial fluid. What's a hemarthrosis? Break that word down. Hemarthrosis. Blood in the joint. Good. Exactly. Right? So what would be the problem with getting blood in a joint? Well, if you get blood in a joint, it's going to limit the range of motion and everything's going to get compressed and you're going to get some breakdown. Ganglions. A lot of times you'll hear of patients getting ganglion or ganglion cysts. A lot of times this will happen either in the tendon or the joint capsule, right? And this is where it balloons up. Like that Baker cyst, which I still haven't figured out. I Googled while I was gone, and it looks like it might be named after a person, but then I saw that it was named after Baker's bending over so much. So I'm not sure which of those it is. But this is where it balloons with fluid due to swelling, right? And that can compress on the nerve especially. Bursitis is inflammation of the bursa. Contusion is a nice way of saying a what? A bump or a bruise, exactly, right? Overuse syndromes, we're going to see a lot, or repetitive use or cumulative trauma disorders. We see that a lot in therapy, specifically in patients that work at desks a lot, right? What kind of an overuse syndrome do we see that patients sit at a desk and use computers a lot, do you think? Low back issues, good, right? But that's not really an overuse. What if I'm sitting here like this all day long? What am I going to get? Carpal tunnel syndrome, right? Carpal tunnel syndrome is an overuse syndrome. It's because you're constantly sitting at this and not taking a break and moving and flexing and stretching and doing all kinds of things with your wrists. You know, when I'm doing coding or when I'm working, that's one of the things, or when I'm gaming, you know, especially if I'm gaming myself, when I'm doing competitive gaming or something like that, when I'm loading into the games, I make sure that I put my controller down and I do a little bit of wrist motion. I do some tendon glides. Yeah, right. And that would be an excellent example. Playing any type of instrument. I played drums, and that was the same thing. You're going like this constantly, and all of a sudden those wrists just get all irritated and out, and just repetitive strain, repetitive use. So all these are going to come into play when you're actually dealing with patients with musculoskeletal issues. So, you know, when we're looking at a patient that's got problems, whether it be with the muscles, whether it be with tendons, whether it be with the ligaments, we're going to look at, is it a dysfunction of the muscles or is it a dysfunction of the joints? Because we're going to treat them differently, right? If we're talking that it's a capsular pattern versus a non-capsular pattern. Capsular, we're going to mobilize the joint. Non-capsular, we're typically going to stretch the muscles. So we have to figure out, is it just dysfunction of the soft tissue or is it a joint dysfunction? You know, what happens if the problem here at your AC joint is that the AC joint is just separated enough that your supraspinatus tendon keeps getting pinched in there? At that point, it's not a problem or a dysfunction necessarily of the supraspinatus, but it's a problem or dysfunction with the AC joint itself. That would be more of a joint dysfunction versus a muscle dysfunction. Now, if you have the supraspinatus and it's the AC joint's patent and functional, but that tendon just keeps rubbing as it's moving in there, now that's more of a dysfunction of the muscle itself or the tendon itself. Contracture versus a tight muscle, because they're tossed around quite frequently, right? When you have a tight muscle, you are on the way to a contracture. So, for example, with my hamstrings, my gastrocs, they're very tight. If I leave them alone, they will eventually contract. Our muscles, if we do nothing with them, will eventually contract up into flexion. We'll kind of end up in that fetal position that we start in at birth, right? When you get to those full-on contractures, that's where it gets really, really, really difficult to stretch them back out, right? Which is why we try to prevent that. When we have a patient that's in for a total hip, a total knee, total shoulder, we want to make sure we're stretching them as soon as we're allowed to stretch them so we don't get a contracture. My younger brother, I remember back, we were at a picnic for my dad was a construction worker at that time, and he was a Teamsters member. And we were at a picnic outside of Lancaster, Pennsylvania. And my brother was deciding that he wanted to show everyone that was kids that he could fly. So he climbed up on the top of the slide and proceeded to jump off. He had a cape on so he could fly. Unfortunately, that was not the best kid's logic in the world, and he ended up coming down and fracturing his humerus. It wasn't a very funny break. Right? So when he fractured his humerus, back in the olden days, you know, back when we all rode dinosaurs to our picnics and stuff like that, and dinosaurs were actually like or the construction crews were brontosauruses, like Fred Flintstone shows. Watch that like it's a documentary. They took him to the hospital, took him to Lancaster Hospital, and they reset his bone, but then they put him in a cast. And when they cast him like this. right? So when they cast him like this, yeah, everyone's going, ooh, right? So I'm cast like this. A lot of his muscles contracted. He was in that cast for about 8 weeks. And so now he's cast like this. And the reason they cast him like this was because as they're trying to fixate the bone, he kept trying to move it. And so they knew that if they just put him in a standard sling, he wasn't going to adhere to the sling. So they cast him up in internal rotation and elbow flexion, right? So now he's here. That bicep is right now shortened. It's going to start by getting tight. Well, if there's a cast there, you can't stretch it. So then eventually that bicep is going to start shortening and shortening until it contracts completely. And it'll start going fibrotic if it leaves it in that position for too long. You'll see this with patients that are strokes that don't get therapy or don't get proper treatment, right? They'll actually contract up and that'll become fibrotic. It can happen in babies in the sternocleidomastoid when they're in utero and kind of get that wry neck. And because they're not able to move that neck, sometimes that sternocleidomastoid will actually become fibrotic. And they may have to go in and cut the fibrosis off to stretch that muscle out. So he was up here like this. So the bicep contracted, his internal rotator is all contracted, everything that does horizontal abduction contracted, or adduction, I can speak, contracted. So his pecs all contracted up, all those internal rotators contracted up. I remember they took the cast off him, and for those who don't know how they take cast off you, they take it off with a saw. And my brother was just a bit of a baby. And this happened when he was, I think he was like 9, if I remember correctly. But they came at him with the saw, and from then on in life, he has had terrified of saws. It's kind of amusing to me, but I'm the big brother, so I can laugh at that type of stuff. But they actually had to sedate him a little bit, give him a little bit of laughing gas because he just kept pulling away as they're trying to cut the actual cast off him. Get the cast off him. So do you think his arm just automatically went back out to normal? Nope. Basically stayed there. You know, gravity may have pulled the hand away a little bit. For the most part, he was there. So guess what he had to do after that? Go to physical therapy. And when he was in physical therapy, they had to torque and really kind of get him out into this posture out here to get those muscles stretched back out. Now, for the most part, he does have functional use of his arm nowadays. He still has a little bit of a hitch in the long head of the bicep sometimes, but that's because he was a kid. Now let's take that to an adult, right? So now let's say you're 50. And you fracture your humerus and they cast you like that. Your muscles, sorry, I hear a little pitter-patter of kids' feet. Your muscles aren't as, not as flexible, they're not as green as they are when you're a kid. So that's going to take a lot more, and you may never get that patient back out to where they need to be. Adhesions can happen when muscles kind of bind down to fascia, fascia binds down to bone, fascia binds down to adipose, right? That's why we have those fascial layers between everything that we have. That provides that nice kind of slick, smooth surface for everything to glide on. Well, sometimes if you're held in a position for too long, those layers will bind down on each other, right? It can happen in the shoulder, happens in the knee, happens actually anywhere. You can get a little adhesion in the chest, right, back. And when those adhesions happen, the only thing we can do is work them out and kind of break up those adhesions so they can do it. Happens a lot in the underside of the scapula, right? So you have that normal scapulohumeral rhythm that allows the elbow or the arm to go up into flexion and abduction, right? Well, if that scapula isn't able to turn because it's stuck down to the ribs underneath it, well, then you're going to be limited. You'll be like, I can get here, but I just feel like I'm hitching. I can't move. And we get back on their scapula and are feeling it, and they're like, oh yeah, the scapula is not moving at all. So what are we going to have to do? We're going to have to get in on that scapula and mobilize it like heck. Oftentimes when I do that lab, when we mobilize scapulas, a lot of you are going to go, oh my God, that feels so good. It's almost going to be creepy for some of you. Like, please do more of that mobilization. Are you okay? Because a lot of us, our scapulas are just really, all the muscles in it are just really, really tight. Reflex muscle guarding. Why would we guard our muscles? So reflex pain, that's our big one, right? So reflex muscle guarding is when you're starting to pull me out into extension with my elbow. I'm going to use my brother's example. So they started pulling him, and instead of relaxing and let them just stretch him out, he would reflex muscle guard and pull in the opposite direction. He would actually antagonize their stretch. Intrinsic muscle spasms. Some of you guys have this occasionally, right? I get it right in my left eye occasionally, where it's like the muscle, like, right? You get those little palpitations of the muscle, where the muscle just kind of freaks out. Yeah, the muscle twitches, right? That can happen to any muscle in your body. And there's some people that are thinking that when you get something like restless leg syndrome or something like that, that involves that kind of muscle twitching going on, or at least when the hippocampus causes restless leg syndrome, which they've kind of figured out the hippocampus has a lot to do with restless leg syndrome, that it's causing those intrinsic muscle spasms that kind of go, hey, just wake up. You don't want to sleep. Does anyone in here suffer from restless leg at all? Yeah, we're going to talk about it. It has to do with lack of activity sometimes too. If you're more active, you have less chance of it. It also has to do with the way the body transmits short-term to long-term memory. There's all kinds of things that cue into it, but it's kind of weird when we get those. Muscle weakness. Well, we all have muscle weakness, right? And typically, again, if you have one muscle that's tight, you're going to have a contralateral muscle, or not contralateral, antagonistic muscle that's going to be weak, right? So if you have one muscle that's tight, the muscle that does the opposite motions are typically going to end up a little bit stretch weak. So if we sit in our forward flex posture here, right, for texting, where's my phone at? So I can properly millennialize myself here. All right, I'm sitting here texting my best friend. Emoji, heart emoji, poo emoji. Good, right? When I sit in that posture all the time, all of my muscles come like this. My head comes forward, and I get that forward head posture. And you'll see this. I love when I like get on planes or I get on trains or anything like that. I love looking at people's heads posture. Right? They have that really far forward head. Well, when that happens, well, some of the muscles are getting really, really stretched out, and other muscles are getting really, really short and tightened. So the muscles that get tight, the opposite muscles do the opposite motion are the ones that are getting lengthened and weakened. Myofascial compartment syndrome, we're going to talk a lot about this when we get into wound care and stuff like that, where they'll do fasciotomies to relieve it. So when you get compartment syndrome, you're getting swelling in an area that doesn't allow a lot of swelling. A lot of times it's in the shins, sometimes in the forearms. And as that swelling happens, it can only expand so far. And once that swelling expands as far as it can, there's only one way it can go, and that's inward. And as we start compressing more of the material, the bone, the muscle, the tendons, the body's going to go, well, this swelling's in the way, so the only thing I can do to take care of it is break down muscle, bone, and tendon. So it'll start eating away at the functional tissue because of that swelling, and you'll get a lot of pain from that. A lot of times the only way they can actually relieve that is by literally laying the skin open to allow that kind of swelling to breathe. You can get that sometimes if you get swelling up or get a problem up in the head. At that point, it's more of a skull problem. It's not really compartment syndrome, but technically it is. I have a video. Did I show you guys the video of the first kid that I treated before that got in a car accident? I don't remember if I showed you that video of Aiden and Aiden's story. I'll have to show that to you. It's a really sad story, but it's a really good story nowadays. I'm a little worried with him because he's now playing football, and this is the therapist that got him better side of me going, why are you playing football? Stop playing football. But he had swelling in his brain from a car accident. And the only thing they could do at that point was literally cut a chunk of his skull out to let the brain breathe. And when you think about that, like, just imagine if you're a parent and the doctor comes to you and goes, the only way we can save your child, the only way you can save your child is by cutting his skull open. Just imagine you guys that are parents. What would you feel like at that point? Would that be terrifying? I mean, I think it would. I don't have kids, and I think it would be terrifying. Just knowing him. Yeah, absolutely, right? It's just crazy. And it could be just your significant other, too, right? Your significant other gets in a bad car crash, and they're like, well, the only way we can save him is by cutting off half of his skull for a time period. What? But that's essentially what they're going to do for myofascial compartment syndrome. They're going to open you up. All right, so sprains and strains are typically going to be graded grades 1 through 3. Out of all of these, probably the most irritating out of all of them are your grade 1s. Grade 2s do have pain with them, but the irritating sprains and strains are your grade 1s. So when you have a grade 1 sprain or a first-degree sprain, you have mild pain at the area of the injury within hours. And again, mild is relative, right? It's almost like West Virginia. Mild is relative. I'm just joking. I'm joking. If anyone's from West Virginia, that was a joke. I'm from Pennsylvania, so I can say that. No, I can't. Mild is just kind of relative with the way the pain is, right? That you get that mild swelling, redness, and warmth in that area. All of us at some point have probably had a grade 1 sprain of our lateral ankle, right? You've gone to step off a curb and the foot rolls inward. And you're like, usually at that point, doesn't matter what type of person you are, colorful words come out of your mouth, and it just kind of swells up a little bit, it's warm. And when you stress it, so when you move it back into that kind of rotated in there, that inverted position, you get more pain. So when the tissue is stressed, you get a little bit more pain. Grade 2 is a little bit worse, right? Grade 2 is moderate pain and it'll stop you from activities. This is where you do that same type of sprain, but now you don't want to walk on that foot, right? You're like, no. And with these, if you can palpate it and you're down there touching around the area and it hurts with palpation, you're now at a grade 2 sprain. So if you're grade 1 sprain or strain and you palpate it and you're not getting any real pain with it, but you rotate it in and you rotate it out and you're getting pain, you've got a grade 1. Grade 2, when you're rotating in and out, you may have a little bit of pain, but when you press on it, you have pain. That's a grade 2 sprain. That's a little bit more severe. You will have some mild fiber tears, right? And when you have those mild fiber tears, you're going to have increased mobility, although the swelling is going to limit your mobility. When it says increased mobility, that just means that the tendons and ligaments aren't able to hold you in place as well, right? They become a lot more lax. Third-degree tears. When you talk to patients, almost they prefer these tears because a third degree is a near complete or a complete tear. The near complete's not so much. The completes are, patients really don't mind them as much. Because when you have a complete tear, you get an instant of amazing, excruciating pain. And then within seconds, the pain is gone. Because at that point, you've not only ripped off the muscle, the tendon, whatever it is, but you've also ripped the nerves. So now you've got no pain, right? Palpation, stress, moving it around, usually pretty painless. The patient's like, oh yeah, no, that doesn't hurt. That really doesn't hurt. That doesn't hurt. A lot of the pain may be relative to the swelling that's going to happen with it. But for the most part, it's not like they're going, oh yeah, when you stretch me way back there, it hurts. You're going to move them all the way back there, and they're going to have instability and actually go beyond those ranges of motion you should have. I remember I did this, again, I'm an idiot, and I am male, so I make lots of mistakes. I was shoveling snow in Pennsylvania, and I had this driveway that was right alongside the road. And so we had these sadistic snowplow people that came through, and every time he'd come through, he'd push all the snow up into my driveway. I'd go out and I'd shovel out my driveway. I'd come back an hour later, snow's pushed up into my driveway again. And the one day I just got so mad of them doing, they must have done it like 5 or 6 times to me. I'd cleared my driveway, I walked out, and I remember there was like a 3-foot wall of ice now in my driveway. So I took the snow shovel and I did the best thing that any guy could do. I started flinging snow into the road. Because if he's going to put it in my driveway, I'm going to put it back in the road, not thinking that the only thing he's going to do now is push it right back into my driveway. But I was mad at the point. And I'm flinging, and all of a sudden I did one of these motions here, and I had excruciating pain under the scapula. And I heard a pop. And I'm like, oh, that hurt. And then I'm like, oh, it's not bad. And I went back to shoveling. Well, I ended up tearing part of my rotator cuff. But because afterwards, it didn't hurt, I just went right back to it. The next thing I know, I go inside and this whole part of my under scapula is bruised, black and blue, and swollen. But that's what happens when you don't pay attention and you're an idiot. The good news is it was like 32 degrees outside, so the cold kept the swelling down. But yeah, so it can happen. A lot of people will do that to their ankles, where they'll rip off those lateral ligaments of the ankles. And once you kind of tear those ligaments, even if you get to that grade 2 where you're starting to get those mild fiber tears, it makes you more susceptible to tears in the future. So you have to be kind of paying attention to that, right? We have a student in the other cohort that's out on clinicals right now that I remember he messed up his ankle in high school playing basketball, And then 2 weeks into the program, he comes in and he's got this huge, big boot on his ankle because he messed up his ankle again. He took they got the cast off, not the cast off, but the boot off, and he was back out playing basketball. He wasn't doing therapy, went out and played basketball again. A few weeks later, comes back into class, big old boot on his ankle again, because he just kept doing tissue damage in that area. Now, the good news is he did go to therapy then, and his ankle's a lot better, but it's still weaker than it's ever going to be. I have that in my left ankle as well. My left ankle is just not as strong as my right ankle. I don't know. A lot of people will find that their dominant leg is usually a little bit weaker for some reason, but I don't understand why. It's no rhyme or reason for it. At least that's what I've encountered. Again, anecdotal, not research-based. So stage of inflammation repair. When we get into that acute stage, they're going to have that inflammatory reaction. At that point that we are in that inflammatory phase, we do not want active motion. So we don't want the patient, if I've got a wrist injury, we don't want them moving the wrist all around, doing stuff. We want that as immobile as possible for a short period just to get the inflammation down. Now we can do passive motion, so we can come in and range of motion them ourselves. But in that acute phase, we really want to kind of tamp it down a little bit and do more passive motion, not as much stretching, just kind of range of motion and keeping that joint kind of patent and functional. We make a mistake a lot of times in our outpatient clinics for those patients that are able to get in to see us immediately, because they'll get in to see us immediately and we get them going, doing stuff right away. Oh yeah, come on, you just injured your back yesterday. Let's go do some prone press ups. No, right? We want them to kind of calm down before we get into that active motion phase. When we start getting out of that acute phase, we get into the subacute phase. This is where we're getting that repair and healing phase. At that point, we can start doing more active range of motion. Start with active assist, and then when they progress and keep going, we're going to get them to active range of motion. And then we get to that kind of lingering, or we call the chronic stage. When we get past that subacute phase, that's where they're either going to get better or end up with this problem where they're kind of stuck with it. And that's going to depend upon how aggressive they are at actually repairing that, how much they're going to work with it. Chronic inflammation occurs because it's repetitive bouts of acute inflammations. They constantly are injuring that, like our friend, the student that I talked about, right? He's constantly injuring his ankle. He's going to end up with chronic inflammation of that ankle, where he does little things like walking around the clinic and he'll get swelling in the ankle, just because you've constantly stressed those ligaments and those joints, and they just don't know how to take it. Chronic pain syndrome we hear a lot about nowadays. What kind of chronic pain syndromes do you guys hear about? What's a common chronic pain syndrome you hear about? Low back chronic pain, good, right? Or fibromyalgia is another one, right? So anytime that we're dealing with these chronic pain syndrome, this is pain that lasts for greater than 6 months. Now, right now, I've got pain in my low back. I guess I could technically call it chronic pain syndrome because I've had it forever, and I'm sure sitting like this is really good for me. But the chronic pain doesn't affect my overall function. I can still do most of the stuff. I can still go to the gym. It just takes me a little bit longer to get up in the morning, right? And I'm sure a lot of you have that. You wake up for that first thing in the morning, and you're like, oh, hello, knees. Good to meet you again. Hello, elbows. Oh, yes, good to meet you. Oh, back, you're there too. Fantastic. And you just kind of wake up, and those are the mornings where you get in the shower and that water hits you and you're just like, I think I'm just going to sit here for a few minutes and let that water warm me up, right? Does anyone do that? Am I the only one that does that? And if you're really like me, when you've got the shower running like that, all of a sudden the next thing you know, you're leaning against the shower wall and taking a cat nap, right? Yeah. Well, I think it might be something traditional with people that are in massage therapy, because we just do so much with our own body that we forget about, or we do so much with our body, we forget about our body, right? Can't tell you how many times I'd tell massage therapists, you need to bring your table up. Stop with it where you're bending over. Should have learned that in school. So again, during the acute phase, we'll have a cellular, vascular, and chemical response. It usually is about a week long, 4 to 6 days, as they say, but a week's where we want to stay out of that active range of motion. So let's say today you guys go out and you're playing with your kids, or you're playing with your nieces or nephews, and they come and they tackle you and you roll your ankle. and you roll your ankle good enough that you definitely felt something there. It hurts. What you should really do at that point is go back to our traditional therapy, right? Back to our RICE, or what we call the better term is PRICE, right? Protection, rest, ice, compression, and elevation. For a couple of days, just don't use that ankle as much. Does that mean you don't walk? No, absolutely. You're going to walk. It's not, unless you have a significant other that can be like, you put a bell out, ding, 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 ding. Yeah, so I injured my ankle. Can you get me my coffee, please? Coffee, coffee. Soda, I really like it. I'm really famished. I could go for my lunch. Unless you have servant or something to do that for you, then, most of the time you're still going to have to get up and move. You just want to limit as much as you can. You want to protect it as much as possible. You may want to wrap it to keep that compression on it, right? At the cellular level, you've got all kinds of mitochondria coming in to repair stuff. Vascular level, you're going to have a little bit of cutting off of the blood vessels, and then you're going to have that vasodilation where they bring in more of the stuff. At the chemical level, you have those chemical mediators of inflammation. You have all those ites, or the zines that come in, right? Your histamine, your leukotrienes, all that cause the swelling to happen. During that kind of protection phase, we want to educate the patient. Okay, Mr. Patient, Mrs. Patient, you've got a sprain of your ankle. You got a good grade 2 sprain. You've got to rest. Well, I work at Amazon. I can't rest. Does that without being injured? That's fantastic. How did he have you get that? I'm just saying, I'm asking for a friend. How does he get you to get his stuff for him? I'm just asking for a friend. But okay, well, that'll work. Yeah, we're gonna keep going. Sip of coffee before I get in trouble. But yeah, so with patients, I know when it's time to take a sip of coffee. I know when that frontal lobe's starting to say stuff and I gotta maintain it. So a patient comes in, they work at Amazon, maybe they're a picker packer, right? And so they're the people that load the trucks, and they've got an ankle sprain. Telling them they've got to rest it sometimes isn't feasible, because maybe they're the only income coming in. And a lot of those places, your Amazons, your UPSs, they love to hire you and pay you really well, but they'll hire you for 29 hours. Why are they hiring you for 29 hours a week? What are they trying to avoid doing? Avoid insurance, right? And avoid benefits a lot of times, right? So benefits being stuff like time off. Because really, and honestly, if you look at the federal laws, there's not any federal laws that they have to give you sick time. Does that strike anyone as odd? Like, there's literally tomorrow, all companies, if they wanted to, could just eliminate all vacation and all sick time. If they wanted to save money, they could do that. And I actually worked at a company that did that once. They came in and they said, well, you know what? I know that you guys really enjoyed your 2 weeks vacation a year, or we're not going to do it. So if you want to take a vacation, you can still take it. It'll just be unpaid from now on. And now you've got this patient standing in front of you that's an Amazon worker that maybe works 25 hours a week, doesn't have benefits, doesn't have insurance, and doesn't have time off. And you're telling them, for about 7 days, you got to rest. And they may be the only person that's providing income in their family. They're not going to be able to. So your next step is you have to protect it somehow. You have to teach them maybe how to do a wrap, maybe get an ankle support for a little while. The main thing is you've got to make sure they don't become kind of addicted to that ankle support. A lot of power lifters get really addicted to their waist belts, their corsets that help them lift really heavy. And why are they using that? Because their core is not strong enough to lift up that weight, and they get kind of addicted. And when you use that, I'm saying addicted like, oh my God, I got to have my belt. What I'm saying is because they've used that so long, the muscles underneath kind of waste away. Same thing with the ankle. You put an ankle brace on for a long period of time, that ankle is going to get weak. So we've got to kind of protect it, but also let them understand you still need to have some normal function. So don't constantly wear it. Ice it, right? Elevate it if you can. Well, no, I'm a picker packer. Yeah, well, same idea there. I hate to say it. Wrist wraps serve a purpose. I mean, don't get me wrong. They serve a purpose and they keep you from really injuring your wrist. And again, this is coming from, I used to do powerlifting. So please understand, I'm not picking on any of you if you're powerlifters, because I had somebody yell at me once before about this. Like, oh, well, I don't care, right? What I found is by using wrist wraps, my wrists became weak. and I wasn't using the strength of the muscle. So I'm much more of a proponent nowadays of lifting what I can lift with the structures that I have. You know, if I can't bench press or I can't squat 400 pounds because my wrist won't let me, maybe that's telling me something. Exactly. Don't force it. Maybe that's my body saying, hey, you know, that's probably not good for you. Does that mean that your leg muscles take a hit? Maybe. So maybe do some more reps, right? But I'm not a proponent of using exterior orthotics to help me do stuff heavier. Although it's funny, is I am a proponent of using gloves in the gym, and it's not to help me. I use my hands on a daily basis in physical therapy. If I have nasty calluses all over my palm and all over my knuckles, that definitely is not going to make giving a soft tissue massage very fun for the patient. I used to do that. I used to not wear gloves at the gym. And then when I started getting into physical therapy and I started doing soft tissue, they're like, ow, why does it feel like you're cutting me with a knife? And I'm looking at my hand, I'm going, oh, that callus, right? So it's all in kind of, it's all relative. If you want to use it, but you're going to weaken over time. Tissue-specific movement, you're going to, again, do passive range of motion as much as possible. Intensity, not a lot of intensity, right? You're going to stay within the range of motion. It's going to be very generalized movement during that acute phase, or that protection phase. Low-dose joint mobilizations. We're going to talk about specifics of joint mobilizations, and it might just be good enough to talk about it here. I don't have a pillow here. Darn it. All right, so I'm going to kind of turn this down a little bit so that you guys can see the cushion beside me. There we go. All right. So has anyone heard of the grades of joint mobilizations before? What the grades go through? Anyone heard like grade 1 joint mobilizations, grade 2 joint mobilizations, anything like that? Have you heard those before? Okay, good. Somebody has. Good. Thank you, Hector. So I'm going to teach you an easy way to simulate those so that you understand, because in the acute or the protection phase, we want very low dose, so your very grade 1 mobilizations. So if you can, find a cushion or something beside you. You can use your quad if you can't do that. You're just going to rest the hand on, and what I want you to do first, before we talk about the grades, I'm going to tilt it down just a little bit more. There we go. What I want you to do first, before you talk about the grades, I want you to push as far as you can until you encounter that you can't go any further, right? That is your maximal amount of joint play when you're doing joint range of motions. You need to know that. You need to know how far I can take that joint. So I've got probably a good, with this couch, if I'm looking at this, I've got a good probably 1.5 to 2 inches of joint play. So when we're talking about grade 1s, grade 1s are going to be low amplitude, meaning they're not going to be a lot of up and down at the very outer edges of my range of motion. So a grade 1, you're literally just taking and barely moving into that range of motion at all. Boing, 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 boing. It's called a low dosage or a low grade joint mobilization. Grade 1s are really, really, really good to help with pain because you're just kind of oscillating it. If you have a sore joint right now and you do that, that little bit of oscillation actually usually feels good. What pain control theory is that working on? Yeah, the gate control, exactly. Good job, Erica, right? Because all you're doing is you're tricking it by doing different things, right? So I'm just oscillating at that end range. So at the very end of my tissue range, I'm just there oscillating. Now, grade 2 is going to be a little bit of a larger amplitude range of motion. So at grade 2, I'm going to push in, go to my end, and stop and come back. So now I'm getting a little bit more, and the couch sounds like it's farting. Right, so now I'm moving it in. That also can be really useful for pain relief because now you're going through that full kind of joints play. And when I say play, it's how much space you have there. And I'm just going through. But again, it's low speed, higher amplitude. Right, so grade 3, we're going to go all the way down to about halfway. We're going to go down to that end range and a little bit into that end. So we're going to stay at half range, going in to a little bit of almost a stretch of that joint. And again, don't worry if you don't get these right now. We're going to do a whole lesson on joint mobilizations. But this gives you a little bit of teaser of what we're going to do with it. And then at grade 4, we're going to go all the way out to that end range, and we're going to go back to that oscillation. That's really good for breaking up adhesions where they're stuck, right? You're going all the way out there, and you're just kind of oscillating back and forth. For all of these, yes, very end for grade 4, and oscillations at the very beginning for grade 1s. So here, grade 1, grade 4, I'm all the way out there, and I'm back to that oscillation, right? When you are a PTA, depending upon the area you live in, they may say you may be able to do grade 1 and 2s. You may be able to do grades 1 through 3, or you may be able to do grades 1 through 4. According to the APTA, it says we can do none of them. But the states are okay to allow their own relief. In our state here, most clinics expect you to be able to do grade 1s, those small amplitude, kind of rapid oscillations. The grade 2s, going out to that end range and kind of stopping. And then the grade 3s, where you start at about halfway, go out and just get a little bit of a stretch going on. Most clinics will expect you to be able to do those. And we're going to go through a couple of those when we do the joint mobilization lecture. When you get to those grade 4s, you really have to be kind of experienced to understand how much I can push on that joint so I don't sublux it or dislocate it. The other thing, when you're doing joint range of motions, they get tiring, right? If I'm doing this for 5 minutes, whoo-wee, you're going to get some burn going on, right? This is almost like the body blade, right? Where you're like, okay, all right, change out, change out. It gets wearing, tired out. Now, there is a grade 5 as well. A grade 5 is a PT only skill. Does anyone know what happens with a grade 5 joint mobilization? That's the pop. Yes, that's the one everyone loves. That's where you're getting out there and you get that, what they call high velocity mobilization. So they get out there, they find that level 5. So they're going to do the same thing you're going to do. They're going to come and go, okay, so there's my total movement of joint play. They might do a little bit of a grade 3 to feel how much stretch they have. They're going to go all the way out to the end, right? And they're going to come down, rapid thrust mobilization, right? A lot of times those are going to be on such stuff like the spine. Sometimes you can do it on the hip and the shoulder as well, right? But that requires a lot of skill to do that. In the chiropractic world, does anyone know what the chiropractors call that? It's not a grade 5 mobilization. What do they call that? Does anyone know? A lot of times chiropractors will call that a manipulation, right? So, and in some states, the chiropractors are fighting the PTs for the ability to do that pop. They'll say, well, manipulations are within our scope of practice, and you can't say you're doing manipulations. So how do we counter that? We say, we're not doing manipulation. We're doing a grade 5 mobilization. Does that make sense? It's a little way to get around their little fussiness. But it happens quite frequently. A lot of chiropractors, and you'll find, if you're interested in getting involved in the actual political side of PT, you'll find that all of us, whether it's physical therapists, and OT usually work with us, speech as well. So the rehab specialists, the chiropractors, and then the athletic trainers, and occasionally the Oriental Medicine Board, we tend to butt heads a lot. And we're always trying to say what the other can't do. Massage therapists. I hate to say this, but I was really, really upset when, what's that big massage therapy chain that's in Las Vegas? Come on, somebody help me out. Thank you. Massage Envy, I heard. Thank you for answering that. So that was from the Peanut Gallery, right? Massage Envy, when they started doing physical therapy stretching, right? Or therapeutic stretching. I forget what they called it now. It's off the top of my head. But I had a real problem with that because they're hustlers. I love it. Thank you for telling me that. At least I know. But they started doing stretching, and nothing against Tyler and even nothing against myself. I don't think stretching is in a massage therapist's wheelhouse. I really think that is a physical therapy skill. Maybe even, I'll give it to the athletic trainers as well, because they've got actually more training than we have as PTAs. But I really think massage therapist's job is manual manipulation of the muscles and the skin and the fascia, whereas stretching gets a little bit into our wheelhouse. And you're right, that's a little bit of a hustle now, right? They say, well, we can do stretching too. Well, now that takes a little bit of business away from PT. And why might they be doing that? Is because some people might have the insurance to go to PT. And that's where we need to get better as PTs and PTAs about our marketing, right? But again, does that not make sense? So I'm going to go down, I'm just going to type out the mobilizations here, even though, like I said, I'm going to re-go over these in the lecture. Let's go with white text. Oh, we got a white background. White text is not going to work. Let's go with purple text. All right. So mobilizations. Grade 1. How would you describe a grade 1? So that grade 1 is just kind of the little gentle oscillations, right? So I often say it's a gentle oscillation. I'm going to spell oscillation totally wrong. At beginning range of motion. Just put wrong one and type it out, right? Let's lengthen this a little bit. There we go. So that's kind of a grade 1. Grade 2 is going to start at that beginning range of motion and go all the way to the end field. And it's going to stop there. So it's a little bit more, right? It has a little bit more of a range of motion to go through, right? It's got a greater kind of curve there. Grade 3 is going to start at about 50% of the way into the range of motion, go all the way to the end feel, and go into the end feel. So it's almost a stretch. Again, this is because we're dealing with joints, we're not stretching joints, right? So it's almost like a stretch. And then grade 4s, we're going to go all the way to the end feel, and we're going to oscillate again. And then grade 5s are really high velocity pop mobilizations. Does that make sense to everybody, kind of? Is there anyone that has a question about those mobilizations? Questions are good, so if you have them, it's okay. So for that acute phase, we're going to start with grade 1s. Maybe if the PT clears it, we might get to grade 2s, but primarily we're going to be grade 1s. So a knee injury is a great example of it, because a lot of times when we have a knee injury, we're going to do patellar mobilizations, where we're going to mobilize the patella inferiorly, superiorly, and lateral and medial. So grade 1, we're just going to literally get on the patella, find the superior and inferior aspects of it, and just kind of oscillate very little, right? And then grade 2s, we're going to go all the way from the beginning to the end, beginning to the end, beginning to the end. Grade 3s, we're going to go about halfway into that end feel and back, into that end feel and back. Grade 4s, go all the way to the end and oscillate again. And then grade 5, I've never seen somebody do a grade 5 patellar mob. I imagine that would be painful. They're going to get that and go a whole way and kind of snap it. I imagine that would be really painful. Just saying. All right, so that's mobilizations in general. And again, we will hit those. Don't totally freak out. There's not going to be a question on your quiz necessarily about this, other than talking about grade 1s for that low protective phase. Muscle setting. So when I say muscle setting exercises, what's the other word you should think of? Muscle setting is synonymous with what other word that starts with an I? Isometric. There we go. Good, right? Remember when we did those quad sets where we're kind of squeezing down and holding it? That's going to be an isometric exercise. Those are the type of exercises we're going to do. So let's say I have a sprain in my wrist and you're doing muscle setting. Well, you're going to want to make sure that wrist doesn't move, and they're going to kind of work those muscles. You can see my muscles going into extension. Maybe I want to work the flexors, right? I'm not going to allow active motion, but that's setting those muscles in an isometric manner to allow it to move. And then here comes Tyler and I, and maybe, I don't think Tyler's the only other massage therapist, and we're going to do a lot of massage, right? Why are we going to do massage? Because again, studies have shown touching a patient makes them feel better. Why do Massage Envy and all those massage companies have such an empire? Because people like human touch. Even people that are, you know, antisocial like me, human touch is nice every now and then, right? And so that massage can be really helpful. It can be really helpful getting stuff that we can't get to. We don't, you know, as a layperson, they don't know how to separate out the, you know, brachioradialis from the compartment of the other muscles in that area. So we have the ability to do that. Oh, I'm still in drawing face. There we go. Get rid of drawing face. Drawing face gone. All right. Then we get the protection phase. We're going to do passive range of motion. We're not going to start resistance until we start getting into the actual return to function phase and stuff like that. But we can do resistive exercises for all other muscles. Just because I injured my wrist doesn't mean I can't do bicep activities, right? It just means I'm not going to hold a dumbbell or hold the TheraBand. I can put the ankle weight here and still work, right? I'm just going to avoid using the wrist at that point. And then functional activities, we may have to tell them, look, if your right wrist is injured, you're going to have to do stuff left-handed. And that can be a challenge for people, right? Try it yourself. One day, just for funsies, go around and do everything with your non-dominant hand. Get your drinks with your non-dominant hand, drink with your non-dominant hand, write with your non-dominant hand, and see how difficult that actually is. You know, telling a patient maybe now it's at work that they've got to do everything non-dominant side, that can be really difficult. Now we get to that subacute phase. We're starting to get a proliferation, repair, and healing. About, you know, anywhere from 1 week to 3 weeks of area. Can last up to 6 weeks depending on how bad the injury is, right? This is why a lot of times therapy is not fun. No, but it's really good training for your brain. That's why a lot of times our therapy prescriptions from doctors are going to be 6 to 8 weeks, because we know that that proliferation, repair, and healing phase lasts about that long. At that point, the synthesis and depositation or collagen's being deposited. I can speak today. And everything's kind of getting repaired. Again, patient education is key here. We need to tell them, okay, you're out of your acute phase of injury. We can start doing stuff, right? And we tell them management of pain. Well, pain is just your body's way of letting you know you're doing something, right? It doesn't always mean it's bad. Pain is just a warning. It's a little bell that goes off in your head, right? And again, pain is up here. Just because you have pain in your wrist doesn't mean that there's something here causing pain. It's your body saying, hey, something's not quite right there. And that's the way your body interprets it. We're going to start getting into some active exercises. We're going to do multiple angles and then some submax isometric exercises, mainly because we can function in multiple angle motion. We're going to do active range of motion. Start building some muscular endurance. And then we're going to do protected weight-bearing exercises, meaning that we might be supporting the wrist if we're doing, you know, wrist curls. We're providing it just a little bit of support. Again, maybe bracing it if we need it. But it's just kind of giving a little bit of support and letting off support as we're able to. Oh, we need that support back. Teaching patients how to really protect themselves during that phase. Stretching is going to come into play at this point, but we have to warm up the tissue, right? We have to relax them. We may have to do some joint mobs and manipulations in order to kind of loosen them up a little bit. Again, manipulations, PT only. Stretching techniques. We're going to go through a whole slew of different stretching techniques, and we'll find what one works best. What you will find as a clinician is you will trend towards one type of stretching. Traditionally, you know, I trend towards PNF stretching because I really like PNF. That doesn't mean that slow and low stretching is bad. It just means I like PNF stretching. And you kind of trend towards it. You may have to adjust your stretching techniques. Sometimes A slow and long hold doesn't work for a patient. We may have to do ballistic stretching, and we'll talk about all those stretches. A little bit of massage again to kind of calm that area down. And then we're going to make sure, I have no idea what that was. We're going to make sure they're using that new range of motion they've gained. So once we've kind of gained a little bit of range of motion, we want to make sure they're in and using that. And then correction of contributing factors. So we need to get them out of their bad habits. If they develop bad habits, this is where we need to kind of nip them. If we don't nip them, they're going to end up stuck in those bad habits. And then once we kind of get into that area, the tissue is going to mature and remodel, and massage can come into heavy play here. If you've got a patient that's got scar tissue laid down, we can get in and do scar tissue massages on them, do a little bit of cross friction, and get that scar tissue to lay the way it's supposed to lay. Say I maybe tore my brachioradialis, right? I've got this tilted a little high. Maybe I tore that brachioradialis. Well, I want my scar tissues to run with the fibers of brachioradialis. I don't want them to run cross fiber because then it reduces my mobility. So I can get in and kind of break up that scar tissue and make sure it's laying the way I want to lay it. And then return to function again. We're back to patient education. You know, patient education's in all of this. We're going to progress their exercises. We're going to start giving them more and more to do at home. Stretching is going to come into play. They're going to be stretching more and more at home. And then we're going to start developing that neuromuscular control, strength, and endurance, which means we're going to start challenging them, doing multiple things at once. Maybe picking up a cup, bringing it back to them, bringing it out, setting it back down, and bringing it back. Start developing the brain to do more functional activities, right? And then at that point, we're going to start returning to the high demand activities. Maybe we've got a soccer athlete that has an ankle sprain. At this point, we're going to start doing soccer drills. And if you don't know what that patient does, look it up or ask them to tell you. Okay, so you're a forward in soccer. I have no idea what a forward does. I'm speaking for myself. I don't know what a forward. I'm assuming that a forward in soccer is in the front part of the team because it says forward. But I don't know what specific activities a forward is going to do versus somebody that's on defensive or whatever they are, right? So I'm going to talk to them. So what do you do? I may even involve their coach and say, hey, you know, Mary's ready to go back to some sports type activities, but I need some low-grade activities to work on with so we can start there. What kind of stuff we can do? Oh, you can start with some dribbling and some general ball control. Fantastic. What does that mean? Right? Get the experts to tell you. If you have somebody in your clinic that maybe plays soccer, talk to them, right? Yeah, I myself, I understand football really well, but American football. I don't understand soccer, and I don't understand hockey, and I especially don't understand basketball. Out of all the sports, I have no idea what's going on in basketball other than round ball, go in, hoop. That's about what I understand about basketball. You couldn't really tell me anything else. Most times when I play basketball, they're usually calling fouls on me because I'm thinking that it's football and I should run you over. But I don't understand basketball. So if I have somebody that's a basketball player, I'm going to find somebody in my clinic or I'm going to find their coach. I'm going to talk to them about what they do. It probably is the easiest sport to learn, but for some reason I am like Neanderthal with it. I can't learn it. I tried. Yeah, probably. You know how I learn a lot of my sports? You're going to find this funny. Like I really wasn't into hockey. Starting a little bit more into hockey. I learned it by playing the game. Going into EA and playing NHL. I think I started with NHL 17. That's how I learned the rules of hockey. That's why I learned what the blue line was. That's why. So probably what I have to do is just get some NBA. And I've told you before, I mentioned this. I'm horrible at NBA. I have no idea what I'm doing in it. Maybe I just need to play a little bit of that and maybe a little bit of the FIFA so I understand what's going on. So when we get into chronic inflammation, the inflammation process is perpetuated, meaning every time we do something simple, we're going to kick up that inflammation. It's going to have an overall weakening effect on the patient. And the more you inflame that area, and the more my back starts getting inflamed from chronic inflammation, the less and less I'm going to want to do with my back. I love football. Football makes complete sense to me. Like every single position of football makes absolute sense to me. Baseball, I understand a little bit. I would not want to put my skills up against you guys that actually coach baseball and softball though, because I'd be like, hit ball out there. There we go. You learn baseball. And catch ball. Ball come to you. Catch ball. Throw a ball to a person where they're running. Good. I'm good. But no, I understand baseball a little bit more than that. But football, I understand pretty well. Martial arts, I understand very well. And we find the martial arts, a lot of the martial arts training is universal depending upon the style. It's just a little bit of change the adaptation of it. But if I'm injured and I've got the chronic inflammation, I'm going to stop doing motion. So my motion is going to start becoming limited, right? So if I've got chronic back pain, I'm going to start staying in this kind of flexed posture because this posture makes me feel best. Actually, for me, this posture kicks up my sciatica. But maybe for me, I might stay back like this, right? So now I'm limiting myself in flexion. I'm trying to avoid that flexion. Well, getting up from this position is challenging, right? So we're going to limit, that's going to limit their motion. They're overall going to limit their function. And eventually they're going to end up with bigger problems than just their chronic inflammation. They're going to end up with contractures, and they could end up with fibrosis and everything going along with that. So we got to try to help them in that chronic inflammation phase. And then overuse, competitive or cumulative or repetitive strain injuries is where we traumatize an area over and over and over and over and over again, right? I think of this because, again, I'm more neuro-based. I like to think of this with CTE. Does anyone know what CTE is? Has anyone heard it? Let's go this way. Has any of you heard too much football? Could be. Could also be too much baseball. Has anyone heard? Let's go this way. How many of you have heard of CTE before? Yes, too many blows to the head. Yeah, Bonbushins. I love Bonbushins. Right, Will Smith's movie. Good. We're actually going to use that, and we're going to use that as a training video eventually. So CTE, chronic traumatic encephalopathy. I'm going to spell this wrong. Encephalopathy. I'm not the best speller in the world. That's why I went into PT, not English. Chronic traumatic encephalopathy. So chronic meaning it's happening all the time. Traumatic meaning it's a trauma that's causing it. Encephalopathy, a brain pathology, right? A lot of times dealing with swelling on the brain. The reason I mention this, because this makes sense to me. Some of the other, like carpal tunnel syndrome, I understand. But CTE, man, I've got, because I literally have CTE and I understand it. So overuse or cumulative trauma or repetitive strain means you're constantly getting that trauma on that area and you don't ever allow the area to heal. I think about when I kind of fought semi-professional or I don't call semi-professionals, not the good term in the martial arts. I call it more not UFC style fighting, where we're actually doing real martial arts fighting. And when you were going to events every weekend and you're getting kicked in the head every weekend, a week is not enough time for the brain to heal from the previous week's damage. And so what you're doing is you're training the brain that it is going to get damaged, and the area that you're damaging is never going to heal. And so you end up in this repetitive injury period where things don't get better. Carpal tunnel, right? Patients are like, and all of a sudden, like, my fingers went numb, it hurts. They go right back to it, rather than treating it somehow or figuring out what's causing it. It can be a re-injury of an old scar. Maybe somebody that's got an ankle injury does the same thing. They re-injured like the student in the other cohort. It'll eventually lead to potential contractions and poor mobility. You know, with CTE, it leads to much worse things like Parkinson's and early death, right? From repetitive blows to the head. But overall, you know, when you do this, this is why we have to stress to the patient. I know you want to get back to sports, right? But you need to let yourself heal. You can't just go right back at it gung-ho. The military is an excellent example of that as well. You know, you get injured, you go see the doc, you go see the medic. The medic says, okay, this is what your problem is. Well, guess what? Get back out there and get to it, especially if you're in boot camp. There's no time for injury in boot camp, right? You're back at it as soon as, you know, you sprain your ankle too bad, tape it up and get back to work, right? So those repetitive trauma to that area will eventually, right? And Michelle's like, yep, right? The repetitive trauma to those areas will eventually cause that area to never heal properly, because the body's going to eventually say, oh, well, I guess Michelle wants her knees to hurt all the time, so we're just going to not heal it. And so then you end up with that repetitive strain, repetitive trauma in that area, and it just doesn't heal right. And then every time you use that area, it gets worse. So what can cause contributing factors to having these disorders? Well, if you have an imbalance between the length and strength of the muscle, you know, if you overstretch but don't strengthen at the same time, that's why you have to have a balance there, right? This happens a lot in gymnasts and ballerinas and dance people where they stretch a lot, but then they don't strengthen those associated areas, and they do end up with injuries. Rapid or excessive repeated eccentric demands. I had a patient that was I forget what he worked concrete. I forget what he had a term for what he does. But his job was unloading trucks full of concrete, the actual bags of concrete. And he told me that how he injured himself is they usually put one person in the truck and they put one person outside the truck. The person in the truck takes the bags and chucks it out to the person outside the truck. So now when you catch it, that's an eccentric loading of the biceps constantly, eccentric. And he ended up getting a bilateral tear of the biceps because of it, right? That doesn't be good. There was a repetitive, excessive, repeated load on those eccentrics. We're designed to be an eccentric load, but we need to rest. Bone malalignment, right? So we talked about that with the patella especially. Changes in the usual intensity of demands. This happens a lot of times to you guys, right? Have you ever gone from just think what's going to happen when we all go back to the gym after this, right? We're all going to be hurt. We're all going to be sore. So PT is going to kick in a lot after we get out of this kind of quarantine. Returning to injury or activity soon after the injury happens all the time. Sustained awkward postures, right? Environmental factors. Maybe you just don't have the proper floors to walk on to cushion, right? I think of the people that work in places like Costco and Sam's Club, and I feel bad for their feet and their knees, because walking on that concrete all day long, that's gotta tear up your legs. I guess Amazon's probably the same way, but I know they've taken some effort to putting in some cushioning in certain areas. Age-related. As we get older, it's harder to train, right? And then training errors. Again, we're going back to our good old-fashioned CrossFit people here. So inflammation, these are kind of just a real simple I have 2 slides. One slide on what to do when the patient's in that chronic inflammation phase. It's just as if they really injured it. So if they're a chronic inflamed person, we have to treat it just like it's a new injury. Every time they get in that chronic inflammation, we're going to have an acute phase, and then we're going to have that post-acute phase. So in the acute phase, in those first 7 days, we're going to do a little bit of modalities, a lot of rest, and then try to figure out what caused the injury to stop it from happening. Then we're going to get to the subacute phase, or the return to chronic phase. We want to get them back towards functional independence. All right, so the next thing we're going to talk about is nerve disorders. Why don't we do you want a 5 or a 10-minute break before we get back into this? 10? Okay, I got 5, I got a 10. Do I have a second? Not 15, we're not doing 15. 5 or 10? How about 10? Does 10 sound good? 7. You guys are just challenging. All right, let's take a 10-minute quick break. We've got about another, all right. So we're going back to talking about stuff, and we're going to talk more about peripheral nerve disorders now and pain management with it. Out of all the things you're going to treat as a PTA, my timer, stop it. Okay, we get it. All right, can you all see the peripheral nerve disorder screen? Yeah, that noise was kind of piercing. Okay, good. So out of all the things you guys are going to treat, nerve disorders are by far the most frustrating, not only for you, but also for the patient. Just because we can't tell a patient with a nerve disorder that they're actually always going to get better. It's really frustrating. You know, when you have a peripheral nerve damage, it may come back, it may not. And I'm going to use myself as an example through most of this because I do have peripheral nerve damage from my brachial plexus. And it helps, I hope it helps hit this home a little bit. Right? So, oh God, do you remember these pictures? The efferent versus afferent nerves. I blocked them from my memory. Well, you might need them back. So I broke the efferent, right? The efferent, which are our motor nerves. That was good. Our motor nerves, right? And I often think, when I'm thinking the difference between efferent and afferent, my efferent nerves affect the area that they're doing. So they're going to cause a motor motion. Whereas afferent is going to cause a signal to go away from the area that we're going back to the brain. So when we're talking about motor neurons, primarily motor neurons, we're going to talk about the alpha and the gamma motor neurons, right? And the only thing that really changes is where the cell bodies are. And this is going to come into play pretty heavily when we talk about upper motor neuron injuries versus lower motor neuron injuries. That's not this class, that's next class, that's Rehab 2, right? And we're going to have to know where those cell bodies are because that'll help, sorry, I had the hiccups. That'll help us tell what kind of an injury they have and what the symptoms are going to be like, right? So here we're looking at the two main types of motor neurons. Motor neurons are going to send a signal from the brain or the spinal cord, right? And effectively cause movement. And then we have our sensory neurons, right? We have our sensory neurons, which are somatic afferent, and then we have our visceral afferent. These are the ones that are going to be sending signals from our distal portions of our body back to our brain to tell us about our environment. All of these kind of have their cell bodies back in the dorsal root ganglion, right? So that means the dorsal root is primarily our sensory nerves, right? Whereas our ventral root is primarily our motor nerves. Doesn't matter if they're sensory or motor, they all kind of have the same body and structure, right? You've talked about that in anatomy, where you've got the little endoneurium, the epineurium, and all that, and then you have the Schwann cells that form down the myelin. All of that comes into play with these. Your main sensory nerves are kind of located out in your body, and they allow your main senses to occur. Your sympathetic or your visceral afferent fibers are located in the body here, and they allow us to react to our environment. Sweat glands are an excellent example. Blood pressure, the blood vessels with blood pressure. Our viscera, our guts, right? And then our glands to release our hormones. Just a very brief overview of it. Nerves themselves are designed so that there's always a certain amount of mobility with your nerves, or what I keep calling play. This is set up so that if there's a force applied to the nerve, it can be stretched and spread across the whole nerve. The nerve fibers are less of just a hard line, and they're more kind of like that loose telephone cord that you see on telephone poles. So they kind of have a little bit of this type of a structure with them. And why is that? So that if one end gets pulled, there's room to lengthen. If we didn't have that play, we could tear our nerves a lot easier. It is really hard to tear nerves. It's not impossible, but it's made to be specifically difficult because those are what's going to deliver and receive messages. Around the nerve, we have our epineurium, right, which is the total outside of it. We have our perineurium, and then we have our endoneurium. Most nerves have movements of about 5 to 10 millimeters. Some of them have a little bit more, like your sciatic has a little bit more. But if you're talking about the specific sensory nerve that innervates your fingertip, it's only going to have about 5 millimeters of nerve play. But that's enough that as we're moving around, as I'm moving my arms here, right, if I had no nerve play, as soon as I reached out like this, I'd rip my brachial plexus off my spine, right? But that can happen, and it happens a lot of times when kids are getting pulled out of the wombs when they get Erb's palsy or whole arm palsy, because they get a little bit of traction force, and that force is greater than that 5 to 10 millimeters, and it just rips the nerve fibers. So we have our nerve roots, right? Where do our nerve roots start? Well, they start once the spinal nerve exits the spine. When we're talking about the upper plexus or the brachial plexus, anytime we're talking about injuries, we're going to define them as upper plexus, middle plexus, or lower plexus injuries. And it's going to depend upon where in that brachial plexus it occurs. If it occurs C5, C6, or above, it's an upper plexus injury. This is where it gets weird because C7 is pretty much your only middle plexus injury, right? And C7, where is the sensory component for C7 at? That's the easy one to remember. Hand, right? And specifically goes out to which finger? Yeah, the middle finger, right? C7 always goes alone. That's why I always remember it. And then your lower plexus, you're getting into the C8 and the T1 region. You can also have a complete or total injury of the plexus, right? Which is what I had when that whole plexus kind of got overstretched. And then it got pinched by the compacting bones. So when we're looking at the nerves that kind of innervate this upper quarter of the body, C5-6 is our axillary nerve, right? And so is our musculocutaneous C5-C6, right? Axillary nerve, what muscles? Give me a muscle that was innervated by the axillary nerve. Give me a muscle innervated by the axillary nerve. The brachial muscle? What's the brachial muscle? Delts. Okay, there's one. Biceps really are actually more musculocutaneous than they are the axillary, but the axillary will branch off. And the axillary, definitely, delts are in one area. Musculocutaneous, now we're starting to talk about the biceps. Then we get down to the median nerve. Now we're starting to get into the hand, right? Ulnar nerve, also hand, and then radial nerve. A lot of your radial nerve is just above the hand in the wrist. So when we're dealing with that, when we have injuries, if I have an axillary nerve injury, you have to understand what I'm going to look like. And that's going to come into play when we actually work through the neuro injuries is, well, what happens if the patient has, if they have a C5 spinal cord injury? What that tells you is the patient has C5, but everything below C5 is probably knocked out or damaged. And so maybe I've got a little bit of axillary, a little bit of delt motion, but I've lost most of the motion in my hands, right? And that gets scary for patients. It really does. You know, I'm going to speak from experience. When I started losing strength and losing function in my arm, and it was my dominant arm, that gets scary because you're like, oh crap. Well, I pick up a lot of things with my left hand. And now I just don't, I mean, you can see a little bit of the palsy in it when I try to concentrate and not let you guys see it when you guys see me. Coffee. But it gets scary when your dominant hand ends up getting injured. Lumbosacral plexus. Gee, I wonder where that plexus is. Could it be in the lumbar region, in the sacral region, right? The peripheral nerves in the lower quarter. You have your femoral nerve, which is typically your anterior compartment of your leg, right? So you got a little bit in your quads and stuff. You have your obturator nerve. Gee, I wonder what muscle that might innervate. Could it innervate obturator and a lot of the rotators? It sure could. You have your sciatic nerve, and your sciatic nerve is your primary posterior compartment nerve, right? When you have patients complain about sciatica, a lot of times that pain is running down the whole backside of their leg. If they're saying, I've got that sciatica and they've got pain in the front of their leg, they're actually misdiagnosing themselves. They probably have a little bit of femoral nerve palsy. Excuse me. You have your tibials and your posterior tibials, or anterior and posterior tibs, which go down to your plantar and calcaneal nerves. You have those peroneal nerves. What side are the peroneal nerves on? What's the other word for peroneal? Fibular. Good, right? So they're out there on that lateral aspect of the leg. But if you look, a lot of your tib nerves and your peroneal nerves share a common origin. They all start from L4, L5, S1 down to S3. So why don't I see any kind of nerves that are S4, S5? I don't see anything here on S4, S5. Okay, you have a little bit on the feet, right? But where's primarily S4, S5 located at? Yeah, your butt and your groin area, right? A lot of that, like your pendental nerve and stuff like that, innervate that area. We're going to talk about that when we get into spinal cord injuries. When you're an outpatient, it's pretty rare that you're worried and working on somebody's S4, S5. I'm just saying. Usually you're going to stop at about S3. But you will have some patients when you have spinal cord injuries where you are concerned about that, where you're going to test their anal sphincter reflex to see if they have any contraction back there. And yes, that is a job we have to do. So get ready when I talk about that. That's always the fun day. When I tell you how you have to test the anal sphincter reflex, you can probably already guess that. So when we have impaired nerve function, it can happen from a couple different ways. And this is going to come into play with spinal cord injuries as well. You can have sustained pressure or tourniqueting of the nerves. Right? That happened in my case when I had the fracture of the spinal cord or the spine. They collapsed. So that started putting sustained pressure on those nerves, and those nerves slowly but surely stopped functioning. You can have laceration, right? Maybe you got a cut, tear, or maybe something happened where you've got your little kid and your little kid's not behaving, and you grab and yank their arm and you get mommy's arm, right? From pulling on them and tearing some of their nerves. You can have overstretch and overshear, right? Where maybe you just taken it a little bit too far. Radiation and electricity are really common in, your manual labor type force to cause damage to the nerves. People that take x-rays for a living, they have a little badge that measures how much they're allowed to spend in radiation, because radiation eventually not only leads to nerve or to cancer, but it can also lead to long-term nerve damage, and you want to limit that. Electricity, has anyone ever accidentally gotten really badly shocked? Maybe grabbed a hold of an outlet that wasn't grounded. Yeah. What do you feel like for a couple hours after that? You don't feel the best, do you? Yeah, your muscles are like, oh my God, I can barely lift that arm I just shocked myself on. I remember I was moving into my dad's, I was helping him move way back when again, dinosaurs were on the earth. And we were moving the washer into the basement. And the washer's got the big voltage plug, right? The 220 volt plug. And evidently when the moving people moved the washer, they got a little bit of a cut in the rubber insulation. And so I'm plugging it in, and as I'm plugging it in, my palm completed the circuit with that little cut of insulation, got a hold of that wire. And I remember my whole body just went rigid. And my dad actually smacked me with a broom to knock me off the plug because I couldn't let go. And for like 2 or 3 days, I couldn't get my muscles to do anything. I was just that sore and just exhausted because electricity kind of messes with you. If you ever have to have your heart restarted because you went into VFib, it can mess with the electrical function of all your other nerves. Yeah, that's the weird part, right? Your brain is telling you, I've got to let go of this. And your body's like, nope, 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 nope. It's kind of wild. All right, so in your book, you have these Seddon versus Sunderland classifications of nerve injury. This is where everyone kind of starts getting scared because they're like, oh my God, there are a lot of big terms in here. Good news is for your boards, they're not going to ask you whether you have a grade 1, grade 2, grade 3, or grade 4 Seddon or Sunderland symptom. You are expected to know that if they're talking about a patient having a grade 1 neuropraxic Seddon injury, that they are talking about nerve fibers. So at that point, they're talking about probably going to ask you and say the patient has a neuropraxic injury to the muscocutaneous nerve. Which one of these activities is going to be difficult for the patient? Well, the muscocutaneous is biceps, so anything doing flexion is going to be one of your major problems. That's what you have to know about these. If you want to take and study these to your heart's content, I put page 393 as the page out of your Therex book for this. I'm going to warn you, it's kind of dry. And the PTs do have to understand each. They have to understand the difference between a neuropraxic injury and axonometrous injury. We don't have to know as much of that. But as you move up the Seddon scale and as you move up the Sunderland scale, you're getting worse. So the higher the number, the higher the level, the more damage is occurring at the nerve level, right? So if you look like a level 1 injury there is primarily an injury of the endoneurium, right? When we get that level 2, we're getting a little bit more damage. When we get level 3, we're getting a chunk taken out. And then we get down to those level 5s where we have a complete separation of the nerve. And so now the patient's really kind of out of luck. But just understand that if they're talking about Seddon or they're talking about Sunderland, they're going to be talking about a nerve injury. So your job is to basically see what could happen with that injury. Is the biceps paralyzed? What's going on? What's going to be the difficulty for the patient? Recovery of the nerve is dependent on several factors. How bad the injury is and where it's at are the major factors. Timing and technique of repair. The faster the patient can get into surgery, the less lingering effects they have. I'm kind of, I wouldn't say apathetic's not the term. Angry would be a good term, that I didn't get my surgery right away. Right? And I don't know if I've ever told you this, but my injury, C4, C3, C4, C5, a little bit of C6. When I first went into, therapy for this, after I had the patient kind of break my neck, I went to see Concentra. And Concentra kept sending the notes over to my workers' comp saying that I had a CN3, CN4, CN5, and CN6 injury. So, Concentra is thinking, I've got a cranial nerve injury. Well, there's no surgery that's going to help with cranial nerve injuries. What I really had was a cervical nerve root injury. So I was delayed about 2 to 3 months before I first got my surgery. Before I even saw an orthopedics or neurological surgeon, it was 2 months before I saw one. That's insane. And all because they were typing the notes wrong. And actually, my PT found it. One of the PTs I worked for asked for the records for Concentric. She was looking to see what they're doing. And when she looked at, they were saying CN, she sent over to my workers' comp saying, no, he has a cervical root injury. He needs to see a neurosurgeon. As soon as that came through, into the neurosurgeon, I was in surgery in a couple weeks. But that whole time really affected how much I gained back, because that whole time I was losing stuff. Age and motivation of the patient. This is big, right? The older we are, the harder it's going to be to repair those nerves. The less we're motivated to repair them, the less we're going to do it, right? I had a great motivation because I didn't want to have to learn a new skill. I wanted to be in PT. I don't want to not be in PT. So I was kind of motivated, and I started my therapy on my own. And this is where the funny part comes into play here. Because studies say that nerves can grow between less than 1 millimeter per day to less than 5 millimeters per day in large nerves. And then you'll look at some studies will say that the nerve will regrow less than 5 millimeters in a year. What that tells you is we really don't understand how nerves regenerate. We just know that there's the possibility for them to regenerate. It's very similar to stuff like your liver and your tongue. Nerves have the ability to regrow, but they may not always regrow the way we want them. If you see on your boards where they're talking about Wallerian degeneration, this is where the axon is completely pulled off the nerve body. If it is completely separated from the nerve body, most times with Wallerian degeneration, it's not going to go back. And if they have that Wallerian degeneration occur where that nerve is ripped right off the cell body, they're going to have instantaneous loss of something. So if musculocutaneous gets a Wallerian degeneration where that axon just rips right off, now that cell body is going to be trying to send signals, right? Because axon away, but nothing's going to be receiving it, right? It's going to send signals out of the little nerve-like stub that it has, but nothing's going to happen. Now, there are studies that say that maybe this can grow back, but for the most part, if you get a complete cut of that nerve fiber off the cell body, most of the times the cell body itself is just going to die off, and then you're going to lose that nerve entirely, right? Axons can regrow, cell bodies typically can't. So what can happen if they have regeneration? Well, some fun things can happen, right? You can have exact reinnervation of target with return of function. So the reason I'm keep talking about the biceps is because I have a fun example coming up here of what can happen if you don't get it right. So if I tear my musculocutaneous nerve, I have the possibility that musculocutaneous nerve goes right back into the biceps and I get total return of function. Right? So if I get an axon tear, it goes right back. Fantastic. That is like gold standard. Great. We're back to normal. We can also have exact reinnervation of that target, with no return of function, or degeneration of the target. So maybe that it's grown back, but it's been so long now that the bicep has completely wasted away. That's a possibility as well. Well, then they're not going to get elbow flexion back entirely, right? If that's completely gone. Sometimes you can get what's called wrong receptor innervation, right? So this is where maybe the musculocutaneous, which is a motor neuron, grows back, but instead of growing back as a motor neuron, it comes back as a sensory neuron. So it still goes back to the biceps, still goes back there normally, but now it's receiving information rather than sending information. The problem with that is, I can smell colors, exactly, right? The problem with that happening is the highways are one way. So that signal is going to be going up and it's not going to go anywhere, right? You're going the wrong way up the wrong one-way street. The weird ones are down here is receptor reinnervation in the wrong area. And this is why I want to talk about it. I had an interesting patient once that had a complete tear of their musculocutaneous nerve. And it did reinnervate, but it reinnervated the triceps. And they had full reinnervation. So this patient was kind of interesting because if you told them to flex his elbow, he extended his elbow. I told him to extend his elbow, he extended his elbow. Because the nerve, yeah, whoa, right? Just imagine how frustrating that is, right? And if you had that ripped off, you know, you may have to, what we eventually had to do was teach him how to flex his elbow with the brachioradialis, right? Which is a little bit more of a radial nerve muscle than in the muscutaneous. But just imagine that, right? The patient, you're going, okay, I want you to bend your elbow. And they're like, okay. You're like, no, I said bend it. And they're like, I am. Okay, how about extend your elbow now? Okay, well, you got that. But every time they do that, the muscle's not working the way it is, right? Or worse yet happens here is that axon just never grows back to connect to anything. It grows back, but it just kind of hangs out there, right? This is like those live wires in your house that are just dangling in your ceiling. You're like, pretty sure that should be terminated somewhere. Don't know what it's for. Or if you've ever worked in a car and you've done electrical work on the car and you get everything wired up and then you have this one wire and you're staring at it going, I know this is supposed to be something. I just don't know what it's supposed to be. That can happen also with the nerve too, where it just kind of grows back and doesn't reinnervate anything, which can be a problem. Here's the deal with most nerve injuries. And I don't know if I have this on this slide or not, but I'm going to talk about it next semester. I don't have it on the slide. Anything they have at 12 months is pretty close to what they're going to have. Anything they have at 2 years out is what they're going to have. The nightmares of electrical engineering, you're exactly right. Same thing with the nerve, right? It is the nightmares of electrical engineering. So at the 1 year mark, if you have not started retraining and getting your stuff back, that's about where you're going to be stuck. At the 2 year mark is where they say, well, at that point, if it hasn't regenerated, it's not going to regenerate. So I use my sensories as an example here, right? I've got motor function. I can do everything, right? Right? We must do our exercises. But I have no sensory function, right? This hand is kind of just dead sensory-wise. I mean, I've got some baroreception, some pressure reception. For the most part, tactile localization is gone. So that my injury was in 2012, I think 2013, I can't remember. So at this point, I'm so far out, it's probably never going to grow back. Yeah, it's pretty much the same for any type of nerve injury. It is, unfortunately. If you have a nerve injury, at the 2 year mark, what you got is what you got. Now, does that mean that miracles can't happen? I don't really call them miracles. I'll call them spontaneous nerve growths. Sure, they can happen. I'll play a game and say it can happen. The chance of you being that 1 in a million chance are pretty low, right? That's just the way it works. And most of the time, one of the first sensations patients get back when they have a sensory nerve cut is pain. And it's funny because when you get that growth come back, when I got kind of the pain function in my shoulder back, it was weird because it was both a aggravating and happy feeling. Because, oh my God, I could suddenly feel something, but at the same time, what I'm feeling is pain. And it was annoying. Right? So you're happy, oh my God, I've got some function that gave me some hope that I could get the rest of it back. But it's just not in the cards. And at that point, you kind of go, okay, well, this is what I got to work with what I got. I don't have full function. As you can see, like here with muscle, if I'm doing a strength test, I can pull apart those fingers. I come over here, those fingers don't come apart. So I've still got some weakness on this side, but it's light years better than it was. I don't drop things near as much with my left hand as I used to. Actually had it happen helping people move where my left hand just decided, you know what, I'm not going to hold anything anymore. It's great. So when we have these injuries and we're recovering from it, in the acute phase, understand if you have an acute nerve injury, all movement is going to be predicated and dictated by the doctor. It is not going to be dedicated even by our PT. The neurospecialist or the neurologist or the neurosurgeon is going to tell us what we're allowed to do with that patient. A lot of times we might just get passive range of motion, and that's just to keep the joints functional and the muscles functional. It's not going to be for anything for the nerve because passive range of motion is not going to do anything for the nerve. There's no retraining there. We're going to do a lot of splinting and bracing, and splinting and bracing are both PTA skills. So you guys can get really good at doing splints. If you are good at doing splints, especially if you work in something like hand therapy or foot and ankle therapy, they will love you, because a lot of therapists and a lot of PTs and a lot of PTAs just aren't good at it. It is a skill for sure, and you can go on to get orthotics specialization and stuff like that as well. It's an interesting field. It's a lot lower impact than doing something like low back injuries all day long. But splinting and bracing are big PTA skills, because the PT just doesn't have time always to do it. The PT is on to the next eval. They don't have time to make splints all the time for people. And then patient education, right? Stop doing. When we get into the recovery phase, we're going to start doing NMES, right, and FES. We're a lot of times going to eliminate gravity, so we eliminate that shearing force on the nerve. A lot of times when nerves grow back, they're going to grow back hypersensitive, so we're going to have to desensitize the nerve. This is where we get stuff like where you get this allodynia, or where pain is really exaggerated. So you touch the patient, and you'll see this a lot of times. You'll touch them, and they're really hypersensitive. They're like, ow, just by touching them, it hurts. Well, sometimes you've got to desensitize that. And a lot of times you're going to do that with Dr. Ovreskin next semester in the hand therapy lab, where you're going to do stuff like rubbing cotton over your hand. And therapists will do this. And the idea is, if I start with cotton, start with something soft, and then maybe move to a Q-tip, which is a little firmer, and then go to something like a towel or something a little bit rougher, and then even go on to sandpaper, just so that you get that nerve kind of calmed down, that normal touch doesn't cause pain. We'll start doing discriminatory sensory re-education, right? Retrain them response to stimulus. We may even do stuff like palmar grasp training, like we had as a baby, that every time something touches your palm, you close your palm, right? You may do stuff like graphesthesia. Does anyone know what graphesthesia is? So I'll type it down here. Graphesthesia, I think I spelled it right. So graphesthesia. So grapha is pertaining to what? Graphesthesia is pertaining to writing. It's like a skin, yeah. So graphesthesia is pertaining to writing. So this is where you may take the patient, have them close their eyes, and draw letters on their hands, and have them tell you what letter it is. I am really bad at this, and it's not nerve injury. I'm horrible at it. Doesn't matter where. You can come on my back and go like, draw a letter, and I'm like, was that a cat? No, I drew a letter A. Oh, I thought it was a cat. I'm just really bad at it to begin with, and it's not even having nerve injury. It's just I'm really bad at it, right? We can do a little bit of baresthesia, where we're training them to recognize different weights, where we'll give them maybe a 2-pound weight and a 5-pound weight and ask them which one feels heavier. And again, patient education is going to be the major thing. If they end up where they are, like I am right now in the chronic phase, the only thing we can do at that point is compensatory training. That means we teach a patient like me, maybe when you're picking up hot things, don't pick them up with your left hand. And I have to constantly be thinking about that. I've done this before where, I'll pull stuff off the stove or pull stuff out of the oven, and I just reach in and grab it with my left hand, not thinking about it. And guess what? I end up with a skin burn. And I look at my hand and go, well, that was dumb, right? I win if we ever do the ice bucket challenge where you stick your hand down in the ice bucket. I'm going to beat all of you. So I can just sit there and go, Eventually I'll get a little bit of an ache from the muscles contracting up, but not much. I'll sit there all day long. I win. You guys got to pay me. It's a nice party trick. So signs and symptoms of impaired mobility. Well, history. We ask them. If we're worried about a patient who has sciatica, we're going to ask them. So when you have sciatica, what specific things are you doing? Well, when I sit, it really hurts. Okay, so when you're sitting, it hurts. Yeah, and when I walk, it gets a little bit better. Okay, good. But when I lay down, it gets a little worse. Okay. And then what we're going to do is we're going to try testing them, putting them in those positions that actually cause it to happen. And patients hate this. If I've got carpal tunnel syndrome from being like this, well, I'm going to put them like this, right? Like voices.
Damn, it's that kind of party?
I'm going to mute Tyler. There we go. I think he just rejoined and left with voice. But we're going to put him in a symptom like this to see how long it takes. So let's do that as a test. What I want everyone to do, put your hands out in front of you, back of your hands back to back, and then lower your elbows. So 29, 28, 27, 26, 25, 24, 23, 22, 21, 20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and let them out. Did anyone's hands go numb? Or you get some tingling going on? A little tingling, right? It hurt, right? Well, think about, what were we compressing doing this? Thumb cramp, good? Okay, not good, but it tells us something. What nerve were we compressing here? Well, we're compressing the carpal tunnel, right? So we're compressing that median nerve. Let's try it a little differently. Now put your hands in, I guess what you call almost prayer position. We're only gonna do 15 seconds of this. So put your hands like this, and I want you to lower your hands so that you get maximal extension of your wrists, and then put a little bit of pressure between them. 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and let out. Did anyone have more signs that way? Okay, so that's what we look at. What we just did there was we tested whether it's a compression injury or a lengthening injury, that maybe your nerve won't stretch enough, or if it's the compression in that carpal tunnel. Just by doing something simple like that. Now Jesse says, I think I'm broken because I didn't feel anything. No, that means you're normal. That means you've got a fairly functioning carpal tunnel area and a fairly functioning median nerve, that you're not getting a lot of signs and symptoms from it. It's a real simple test we can do. But if you have a patient that's got really bad carpal tunnel syndrome and you put them like this, they hate you. Because as soon as you do that, these three fingers are either aching and sore or cramping thumbs. Like, oh yeah, you get to like 5 seconds, like, okay, I'm done, checked out. Nope, 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 I don't like that at all. Or when you get this way, right? Now that carpal tunnel's open way up and that nerve is stretched out about as much as you can get, and now you're causing irritation that way. You can't get the extended elbows, it doesn't allow you to do that, but if you could extend their elbows, you'd stretch it even further. So we're gonna provoke them, we're gonna cause it, and we're gonna, okay, document everything we see, right? And then we're gonna ask them, well, what about heat and cold? Do either of those make it better or worse, right? We're gonna constantly ask them causes of their symptoms. And then we're gonna manage it. We're gonna look at maybe getting some splinting. We're gonna worry about making sure that everything they do is right. We may have to go to their job and see what their job site looks like and do a work site evaluation and see if maybe they're, like right now, where my computer is not the most ideal for me. You know, normally I have an inclination on my computer, but if I incline my computer right now, my wrists are going to be way bent back. So I don't want that. I have it flat right now, which is not helping the heat at all, but hey, compromises. So we're going to look and see how can we manage their condition and maybe prevent them from getting further problems. And then precautions or contraindications to neural tensioning and testing. Here's the deal. If the neural tensioning and testing causes them extreme pain, they need to see somebody specialized in nerve injury, so seeing a neurologist. Because we have to make sure there's not a ganglion or a cyst pressing down on that nerve. And a lot of times you can see it. If you get a ganglion or a cyst in your wrist, you can see it. But we may not be able to help with that until they see somebody that actually excises it or removes it. If the patient can't feel, so maybe they're insensate, you know, they completely are anesthetic. Well, doing this is not going to be very good because we can't tell when we've done too much, right? Stretching them. We're not going to be able to tell when we've overstretched the nerve fibers. So those are going to be some precautions, contraindications. Really, when we've got a patient that's doing this, they should be seeing a specialist in whatever field they're having problems with. You know, if they've got a hand injury, they should be seeing a hand surgeon or hand specialist doc, right? If they got lower back injuries, they may need to see a spinal doc. You know, you got a knee or an ankle, you may need to see a sports doc just to get checked out before we do a lot of stuff with them on those nerves. So, yep, I'm moving on right here. So median nerve. A lot of times when the median nerve gets compressed, it's either going to be in the thoracic outlet up here between the anterior scalene and the middle scalene. It can also happen down in the carpal tunnel. Radial nerve is going to happen with tennis elbow and dequerre veins where we have thumb problems. And then ulnar nerve a lot of time is going to lead to medial epicondylitis, right? So when you have these nerve injuries, you have to understand where they go. So let's start with median nerve. Median nerve is going to start up here in the brachial plexus, right? I'm going to kind of, there we go. Oh, let's tilt down some. There we go, a little better. It's going to start up here in the brachial plexus and go down kind of the middle of the arm, right? So it's going to exit through the middle part. What's this area here called? What's this fossa called? We'll talk about, do we do that in a second here? That way I can see what you're talking about. What's this fossa here called? The olecranon fossa is back here. This is the antebrachial fossa. Have you ever heard that before? Sure, it's where they draw blood from, right? When you ask, do we do that, what were you talking about? Adrian, do we do nerve flossing, nerve testing? Is that what you're asking? If that's the case, then absolutely. We won't do it initially, but we will follow up the nerve testings when we do stuff. Oh yeah, absolutely. We can do job sites. There's work hardening is it's a big field in PT. Culinary has 1 or 2 PTs and 1 or 2 PTAs on site or on call that will go out and evaluate job sites. Right? Because it helps them understand what they might need to change in order to prevent injuries. Because for a company, it's a lot better to have a PT or PTA on payroll that can go out and assess what needs changed than it is to pay for injuries. It is interesting. It's a really cool field. Work hardening, to me, it's a cool field. It would be boring for me to work in it, but it's a really cool field to work in, if that makes sense. So median nerve goes down here, right? Radial nerve is going to come out of that same brachial plexus, right? And kind of come down here in that lateral compartment and go out to your thumb. Your ulnar nerve then is going to come down here and it's going to go back behind the elbow through that olecranon area and then down here and go to the medial aspect of your hand. So a lot of times if you've got radial nerve injuries, you're going to have problems with the thumb. If you have median nerve injuries, it's usually those 3 fingers there. In ulnar, typically it's going to be out here in the pinky area, right? And we're going to talk about when you get into hand therapy, with Dr. Ovreskin, talk about thenar wasting versus hyperthenar wasting and which nerve is injured in that. If you have thenar wasting, a lot of times it's median nerve. If you have hypothenar wasting, a lot of times it's ulnar nerve. So this is kind of what we're going to do when I get back to my home. We're going to actually do some nerve tensioning to see how it feels on you all. As pictures, we'll talk through it and do it together, so don't worry about the pictures right now. With the legs, we can do the same thing. We can do sciatic nerve testing, femoral nerve testing, and everything like that, and we're going to do that as well. So we're going to talk about a couple symptoms, and we'll cut it loose for the day here. Thoracic outlet syndrome. This is where the nerves and the blood vessels exit the thorax and go out to the arm. Carpal tunnel is associated with this. Problems with blood pressure out in the arms are associated with this. Symptoms a lot of times are going to look very similar no matter whether it's carpal tunnel or what's vascular related, right? It's going to say they're going to have pain and numbness going out their arms, and a lot of times it goes out that median nerve distribution. Oftentimes, the actual compression or site of the compression is up here in what we call the scalene triangle. So you have your anterior scalene, your middle scalene, your posterior scalene. Well, right between the anterior and the middle scalene is a little hole called your scalene triangle. And that's where all those blood vessels, nerves dive out. There's a little hole for them to escape, right? So the abstinence test, we're actually going to do this on probably Thursday, where we can actually test and see if you have problems with that scalene triangle where you have some compression. You might suffer from thoracic outlet syndrome. What we're going to do is actually put you in a position where your pulse will go away if you have problems. It's a really fun test, and it's something you can test on your family then, but we'll do that as a group so that you can understand exactly how to do it rather than doing it today. Well, the key thing here is if we know that this provokes the problem, what we have to determine is the problem in the hand, Is the problem in the wrist? Is the problem in the elbow? Is the problem in the shoulder? Or is the problem up here in thoracic outlet? Because all of those are viable places where the problem could occur. And so we may have to do stuff like EMG testing, where we're actually testing where the signal gets blocked off. And PTs are trained, or supposed to be trained in doing EMG training, but a lot of them only do it in school and then never do it again. But we're literally going to put little sensors and determine where that signal kind of dies out. If they have these problems, well, we need to stop them from doing stuff that provokes it for a time being until we can get it solved. And we want to preferably do non-operative management. The doc, if you have carpal tunnel syndrome, is going to tell you right off the bat, you need surgery. We need to open up that carpal tunnel. And again, what we find is patients that go in and show carpal tunnel signs, they'll get that surgery to relieve the carpal tunnel and the symptoms don't go away because the problem's actually in their neck. And maybe if they got non-operative management first, they might have avoided the surgery in its whole because we realized that tightness of the scalenes or something, the stretching the scalenes relieves it. But again, if you go to a surgeon wants to cut you. If you go to PT, we're going to want to do PT on you. That's kind of the jobs of each of us, right? So Adson's test, this is kind of the way to go through it. So you're going to find your radial pulse. You're going to passively extend, abduct, and externally rotate the arm. The patient's going to take a deep breath, hold it, and then they're going to rotate the head toward the arm and extend the neck. We'll do that, like say on Thursday, and if it happens, if you have a positive Adson's test, the pulse will actually go away at the extremity. That tells us you are positive thoracic outlet syndrome. Now, if the test doesn't show anything, the pulse doesn't go away, that doesn't mean you don't have thoracic outlet syndrome. It just means that maybe the blood vessel is not being compressed. It's actually really cool when we do this, and we'll try this, and then I'll have you guys try it on your family at home. CTS, or carpal tunnel syndrome, again, happens down here in the carpal tunnel. And when you actually see what goes through that carpal tunnel, and unfortunately we didn't get to go to bodies. Maybe we'll have to see if we can take a field trip to bodies. Because when you see the carpal tunnel laid out and you realize how much goes through that carpal tunnel, you'll understand how people get carpal tunnel syndrome. Because there's a lot going through it. You know, we're going to examine them. Do they have a history of carpal tunnel syndrome? What are some positive findings? We're going to do Phelan's tests. We're going to clear other areas. What if they have a double crush where they have a crush injury here and they have a crush injury in the elbow? Well, that's going to cause all kinds of problems because we fix one, we got to fix the other too. A lot of times when you have carpal tunnel syndrome, like I said, these are the fingers that are affected, right? Kind of your pincher grasp fingers. And that in here, in this area right under the thumb, you're going to have wasting. And wasting is where it kind of sinks in. And I don't know if you can, I'm going to try to get my hands up as close as I can here. I don't know if you can see the difference between my left hand and my right hand's thenar eminence right under my thumb. But if I move them around, you can see that that left one kind of sinks in a little bit more than my right hand. I've got a little bit of thenar eminence wasting in that left hand from my nerve injury. When we're dealing with this, obviously we, as PTs and PTAs, we want to try to push them towards non-operative if we can. Because, again, anecdotally, I'm speaking for myself, patients that I've seen come out post-carpal tunnel syndrome surgeries often are worse off because they're actually going to open up the carpal tunnel and take out a retinaculum that holds all that stuff down to give more space. But now you've got a more open area that you can injure easier. If they do have surgical management, we're going to go through the same phases. We're going to go through a maximum protection and a minimal protection phases where we improve them. Yeah, minimally invasive surgery, exactly. What is minimally invasive? Because it doesn't require as much as maybe a total knee replacement. But man, they cut that open, now you've got, your structures aren't as strong. Ulnar nerve compression can happen in the canal of Guillain. Does anyone know where the canal of Guillain is? Because you have your cubital tunnel and your canal of Guillain, or where your ulnar nerve passes, right? So canal of Guillain's down here on the lateral compartment of the wrist, or medial compartment of the wrist, I'm sorry. See, even I'm getting tired. And then your cubital tunnel is back here, right? Cubital tunnel, we often have a very funny name for it. What do you think we call the cubital tunnel? Because it's very funny. The funny bone. We call it the funny bone, right? Did you ever do that where you bang your elbow and all of a sudden your hand goes numb? Right? That's cubital tunnel where we end up banging off that ulnar nerve. And a lot of times these, the two fingers out here, the tinglies, right? And you can even do that. You can take and kind of get your elbow out here and kind of tap and get those tinglies going. I'm doing this purposely on my left hand so I don't feel it because I don't like the feeling. And we'll do that. Those are some of the tests we're actually going to do when we look at it. Well, in this case, right, so if we have median nerve, these fingers are eventually going to contract. If we have an ulnar nerve wasting, these nerves are going to contract. So we're going to limit and kind of keep them from doing stuff that makes this worse. And then we're going to try to improve it. We may have to do some ultrasound to kind of relieve any adhesions in there. We're going to have to get them moving again. A lot of times, if you have median nerve injury or ulnar nerve injury, it's probably better to see a hand specialist, a hand therapist. Whether it's OT or PT, doesn't matter. They're going to be more specialized than your general sports medicine person to work on the hand. I know we're all trained to work on carpal tunnel injuries, but if I have an injury like that, I really want to see somebody that's a specialist. So complex regional pain syndrome. Has anyone ever heard of this? CRPS? Anyone? We're almost done, I promise. Right? So, you know, right. So complex regional pain syndrome, we have CRPS1 and CRPS2. It used to be called reflex sympathy dystrophy, right? Or causalgia. We've now kind of limited them or named them into CRPS1 and CRPS2. This is where you get a nerve-like symptoms when you either have an irritating event or don't have an irritating event. And it's going to cause constant burning and pain in those areas that won't go away. A patient that has CRPS really is in a ton of pain, even though there may not be a cause for that pain because it's nerve related, right? It may not be that they can say, oh yeah, you know, yesterday I banged my elbow. Well, that can cause it, right? That would be a CRPS type 1 injury, but it could be a CRPS 2 injury where they maybe stretched a nerve too far and now it's irritated, and that's a causalgic injury where we don't have a specific reason for the cause. A lot of times they're going to be in the arms. You have a lot of patients that have CRPS of the arms. And again, Dr. Ovreskin is going to hit this a little bit more heavily next semester because she covers the upper extremity more than I cover. But at least understand that a patient with CRPS, their nerves are overactive. So we're going to have to calm them down somehow, right? Mirror box therapy is a fantastic way to calm these nerves down, where we put their hand in a mirror and we normalize. So we take the hand that's normal functioning and we have them in a mirror where they see their left hand, right? But they see a mirror image of that left hand, and that left hand is now the right hand as well. So when they open and close their hand, they don't have the pain. Sight is amazing. Even though they're not even doing anything with this hand, they'll feel that hand moving. And it's pretty wild. We do that a lot with patients that have phantom limb syndrome as well, where they maybe had an amputation. Amputations can lead to RSD, where they have that kind of, right, a phantom limb, right? In reality, when you look at an amputation of phantom limb is really an RSD or CRPS type syndrome, where they're having a symptom where it may not be, you know, it's well beyond their previous event. There's all kinds of things that go along with it. Again, I put these on here. Understand Dr. Ovreskin will go over them more in depth with you next semester. I'm not gonna, if you're gonna work on these, talk to your PT that you're working on them with. When they're acute phase, if we've got CRPS, this is the one thing I want you to know about CRPS. There is an acute reversible stage. If we can get them into therapy and if we can see them in that acute phase, we can reverse CRPS. But if we let it get to stage 2 and stage 3, where they're out of that acute phase, the only thing we can do is mitigate the symptoms. We're not going to totally reverse it, right? So if you get in stage 2, we're starting in dystrophy where the muscles aren't working right again. And we're going to get ischemia happening where we're actually going to lose some blood flow to that area. And then when we get stage 3, at that point, the muscles are just going to start wasting away because of the nerve problem. And the muscles are just going to turn off. And we don't want to get there. So they want to get in. If they suspect they've got a nerve injury, the doc should be sent into therapy right away. And again, Dr. Ovreskin will cover this more in depth next time. All right, so I stopped screen sharing. That is it for our long 4-hour session. Oh my God.